But that is the importance. If we can rectify our diet, probably we do not need ADIs. So that is my thought, whatever I am saying, but this is just what is mentioned. So again, these are only prandial glucose regulators. They cause a very minimal reduction in fasting plasma glucose. Now this is just an overview. So we know these are all the relatively old or old. 60 years, I don't think today's date it is old. So sulfonylureas do not become old by that criteria. So the sulfonylureas, meticulous, metformin, thiazolidine diols and alpha glucosidase inhibitors. The efficacy more or less same, excepting for AGIs which are slightly lower. Hypoglycemia tendency definitely very high with sulfonylureas. The other drugs are relatively much less. If you talk about weight gain, yes, sulfonylureas do cause. Thiazolidine diols also cause, but that is because of the fluid and sodium retention that they cause. Side effect profile, sulfonylureas notorious because of weight gain as well as hypoglycemia, and similarly thiazolidine diols because of again weight gain and sodium retention. And the controversies of heart failure. The cost, again you can see the sulfonylureas and the metformin, they are the lowest price. So in a country where still majority of the population is in rural areas and they don't want to spend money on medications. If you prescribe 50 rupee drug like Dr. Sahib would say, so then it will be a problem. Patients don't purchase. They will think for 3 visits and the doctor when 4th visit says now don't come to me if you are not taking, then definitely they will take. Hopefully. Not definitely, hopefully. So that is again now beta cell preservation obviously. Sulfonylureas, meglitinides we do not have any evidence and probably they are the culprits. There is an old saying that don't whip the tired horse. So sulfonylureas actually are considered to aggravate beta cell failure. And if you talk about metformin, thiazolidine diols and to some extent metformin, thiazolidine diols, yes, they do cause beta cell preservation because they do reduce insulin resistance. Now again pregnancy, you have the oldest drugs, the greatest experience we have, and probably that is why sulfonylureas and metformin have been used in pregnancy, knowingly or unknowingly, but without any side effects. And funding I alluded to, I am not going to write down anything about funding here. I don't have a conflict of interest here. So just to end my slides, last slide, safety and tolerability profiles. These are just some reviews which I would just like to highlight. Just see the highlighted 4th, 5th line, 4th point. The cardiovascular outcome was similar and no excess report of cardiac failure with pioglitazone or glycoside were reported. This was a study around about 2005, yes, 2005. But then we had a number of trials, 2007, DREAM, etc., which said that there is a increased propensity to heart failure. And this is a analysis by the Johns Hopkins University in 2011. You can see 140 trials, 26 observational studies, and they compared the second generation sulfonylureas, thiazolidine diols, meglitinides, DPP-4 inhibitors, and GLP receptor agonists as monotherapy and in combination. And you can see sulfonylureas had a 4-fold higher risk for mild or moderate hypoglycemia than metformin, which we already accept. And thiazolidine diols increased risk for congestive heart failure compared to sulfonylureas. So if we have some cardiovascular risk with sulfonylureas, probably the risk with thiazolidine diols would be 4 times more. So this is what was a detailed analysis by the Johns Hopkins University published in 2011. Now again, this is same time next year 2012. You can see cardiovascular disease and OHAs in type 2 diabetes. For sulfonylureas, the support for reduction in MI came from the UK PDS extension study, extension study which I said earlier. And the other studies do not support the view that metformin and sulfonylureas differ with respect to myocardial infarction or indeed cardiovascular outcomes more generally. So probably all drugs are the same, whether metformin or sulfonylurea. So whenever we have doubt, we try to search for Cochrane reviews in our academic circles. We try to see that if somebody else like Cochrane reviewed investigators have done some very nice work, and I just ran through that. So 2003, this is on sulfonylurea monotherapy for type 2 diabetes. They assessed all these randomized controlled trials till 2011. They published in 2013, and the primary outcomes are all cause and cardiovascular mortality. And the results are, these are all the details, how many participants, etc. But the results are here for us to see. I think we can ignore the first 2 lines because they are versus first generation sulfonylureas, which we are not bothered about now because we do not use them anymore. But you can see second generation sulfonylurea versus metformin. Composite, non-fatal, macrovascular outcomes favored sulfonylurea. So sulfonylurea is actually better than metformin according to this review till 2013, whatever publications are there. And if you see for other, there is no difference. So all other points, there is no difference. Second generation sulfonylurea versus metformin versus thiazolidinediones versus insulin versus incretins and versus magneticides. They are equal in all respects for whatever studies have been conducted. So for whatever studies have not been conducted, I don't think we should premise anything. But this was 2013 issue 4 Cochrane Library. So Cochrane issues are considered non-committal, not funded, and they are considered the best academic data on hold. So I think this is just the conclusion that I said. Another study 2013, no report of increase in incidence of CV events with use of sulfonylurea. And this is just an anecdote to end. One day Emperor Akbar drew a line across the floor. I know you all know the answer, but still, Birbal he ordered, you must make this line shorter, but you cannot erase any bit of it. So there was an eraser and he drew a line. You cannot use the eraser, you cannot draw, you cannot erase it, but you have to make it shorter. Everyone present thought the Emperor had finally outsmarted Birbal, and it was clearly an impossible task. But obviously, some people have to do something. So Birbal simply drew a line longer than the first. So this point is, so now the earlier line became shorter. So this point I am just anecdote, I am just telling you people, revising you rather than telling you, is because these days whatever cardiovascular outcome trials we do are non-inferiority trials. So they just compare one drug against the other. So if we compare sulfonylurea versus metformin, we are just seeing sulfonylurea is not inferior to metformin. So they cannot prove that cardiovascular outcomes are much greater in the other study. So this is what we are supposed to realize, that if we have to prove that other drugs are better, then we have to do a superiority trial, which will require a very great investment, and probably that is why we are continuing to do non-inferiority trials, and so all drugs would be equal. What will be better will, I don't know when we will come to that point. So this is my concluding slide. I think I already said it. So old experienced family doctor versus a young recently graduated doctor. So we have to decide who we are going to seek help from when we fall ill. And 50 to 60-year-old drug, obviously in our profession, graying does matter, and we become a good practitioner like Dr. Sahai because he becomes grey haired. So I am not yet so experienced, so I still think that 50 to 60-year-old drug is not an old drug. And especially if you compare with designer drugs, which are toddlers, not even teenagers. Thank you so much. Thank you for waiting.
Thank you, Mr. Anupam Prakash. It's a good lecture of sulfonylureas and other OHS. But in the upper board, actually the metformin still stands the first line of drug for the newly diagnosed diabetes. And but for the burning out of the pancreatic beta cells, use of sulfonylurea stood in the backbench, but the use of the OHS still finds a good place in Indian population, where they are very poor rural population. They are relatively cheaper drugs. In our state, actually, the government supplies the sulfonylurea plus metformin free of cost for all the rural population, because that's very cheap and 60 paise drug. Most of the time, the Indian rural population these are not bored as we think, but in the advent of newer insulins, DP4 inhibitors, escalate inhibitors, Saha is going to speak. Definitely, the prevention of complications is better with the newer drugs, but as a whole, the OHS are very good drugs, as you said, for Indian population. Any questions on this subject?
Sulfonylurea have a limited life. After 5-10 years of diabetes, it becomes and these are drugs called maximum hypoglycemia. Whenever
I think I have another talk, and whatever you are saying, some part is covered there. So I think we will just have all the discussion together, because this OHS and insulin will all we club together.
I request Dr. Syed Ahmed and Dr. Boka Venkata Satyanarayan to present the memento to Dr. Anupam Prakash. I request Dr. Anupam Prakash to present the memento to Dr. Syed Ahmed Kabir and Dr. Venkata Satyanarayan. For the next section, may I request Dr. Rishad Ahmed and Dr. Ramakrishna Reddy to come on the stage, and Dr. Rakesh Sahay to take the session on newer rural drugs.
Good morning, everyone. So we have been talking about fathers and grandfathers. So now we will be talking about toddlers and teenagers. So without much delay, I would request Dr. Sahai to begin his talk. And hopefully he will be discussing on gliptins and SGLT2 inhibitors. Thank you. Dr. Sahai.
Good morning to all of you. At the outset, I would like to thank Professor Munjal and Dr. Nandan for inviting me to be here, and Sinsan Pharma for organizing this event. And at the outset, let me say that Dr. Anupam, let me congratulate Dr. Anupam for the excellent presentation that he has done. And I would like to say that as a disclosure that it's not I'm probably speaking fewer times. I've spoken fewer times for the newer drugs than for the older drugs. And recently I remember debating in favor of the older drugs. So it's not that I'm speaking for the newer drugs, but I'm speaking about the newer drugs now because that is the job given to me. So I would like to and Dr. Anupam has given a very good overview of the older drugs. He has shown us the place they have in therapy, and I would like to also add that in our practice also, I would be using the older drugs more often in almost all the patients, and maybe the newer drugs in some of the patients who need them for the benefits that they provide. So what we have been seeing since yesterday is that we need to reach the goal for the glycemic goal that is required has to be reached so as to prevent the complications of type 2 diabetes. And whether or not we find that we don't reach this goal in most of our patients. So we need to often add on more and more drugs, and we know that since different mechanisms are playing a role in the development of hyperglycemia, we need to use combination therapy. So very often what we see is that we need to use the old drugs, and we need to combine them with the newer drugs in many of our patients so as to be able to reach this goal which we are looking at. And what we also know is that we have this additional cardiometabolic risk factors which have to be favorably modified so as to reduce the risk for the development of the cardiovascular disease, which is the major problem. And as has been shown very elegantly since yesterday, that the earlier we do this, the earlier we reach the goal, that is early in the course of diabetes, that we are able to have a better legacy, and we are able to sort of prevent the long-term mortality and morbidity which is associated with the cardiovascular disease and diabetes. So we need to sort of, and we also know that there are several barriers to reaching this. Hypoglycemia is an important issue which happens in many patients, and that actually once it happens, it creates a fear amongst the patients to use adequate therapy to reach the goal. So therefore, hypoglycemia is something which is something which can be troublesome. Weight gain is another issue which is an important issue which we are discussing, and Dr. Anupam has highlighted that these issues are there with sulfonylureas in some patients at least, and therefore they need to be used have to be avoided in these patients who have got high risk of hypoglycemia and weight gain. And then glycemic variability is another issue, and the durability of action, that is the duration for which the glycemic effect is maintained for is something which could be a potential limiting factor for some of these drugs, and the quality of life. So these are the issues that we're looking at. So looking at these issues, we need to see whether how the different drugs stand out and how we can choose wisely so as to prevent these problems and provide a better quality of life. And today, if you look at the pathophysiological mechanisms which are playing a role in the development of hyperglycemia in patients with diabetes, we have several different mechanisms which have been identified. There are 8 different mechanisms which have been identified, and right from the insulin resistance, which comes on very early. Then only when the insulin secretion starts coming down, then the person develops diabetes. But in addition to these 2 mechanisms which are addressed by the conventional agents, we have several other mechanisms like the increased hepatic glucose production, increased glucagon secretion, and then decreased and also increased glucose reabsorption at kidneys, which are all also contributing towards the development of diabetes. The decreased incretin effect also. So these are some mechanisms which are being addressed by the newer agents, and we have some more mechanisms like the neurotransmitter dysfunction and other mechanisms which are probably not covered by these 2 agents. So I would be today in this talk I would be discussing about the DPP-4 inhibitors, which are particularly trying to overcome this incretin effect, and also the SGLT2 inhibitors which are working towards decreasing the glucose reabsorption from the kidney. So if we look at the incretin effect, very briefly, what I would like to say is that in patients, in normal subjects, when you look at the same amount of glucose being given orally versus intravenously, you find that a greater amount of insulin secretion is produced when the glucose load is given orally, as compared to when it's given intravenously to produce the same rise in glucose. The same rise in glucose is produced with the particular glucose load. The insulin secretion is more when this is given orally, and that is what is called as the incretin effect, and that is because greater amount of insulin is secreted in response to the oral glucose intake. And this is diminished in patients with type 2 diabetes, and that probably is one of the factors contributing towards the development of diabetes. And this is again shown here in the form of a pictorial diagram which shows that in response to the oral intake, there is insulin secretion which is happening. This insulin secretion is in response to secretion of certain substances called the incretins, the GLP-1 and GIP being the major ones, and they contribute towards the glucose-dependent insulin secretion. And the important issue is that the GLP-1 is broken down very rapidly to inactive form, and this can be inhibited by either using inhibitor to this DPP-4 enzyme which causes breakdown of the GLP, or using GLP analog which is resistant to breakdown by the DPP-4 enzyme. So these are the 2 mechanisms by which we can harness the incretin effect. And we know that incretins are lower in patients with type 2 diabetes, and to enhance the effect of the incretins, we could have these two different mechanisms by which we could reduce the hyperglycemia of diabetes by increasing the incretin effect. And this is how the DPP-4 inhibitors would work. They are going to suppress the breakdown of GLP-1 by the DPP-4 enzyme, and that leads to greater amount of glucose-dependent insulin secretion, and greater amount of that once again leads to increased glucose-dependent insulin secretion and suppression of glucagon secretion from the alpha cells of the pancreas. So, in addition to the effect on the pancreas itself, the DPP-4 inhibitors have additional benefits in terms of suppressing the glucagon production from the liver. They also suppressing the hepatic glucose output by suppressing the glucagon production, and they also have a regulation of the hepatic glucose output. And in addition, they promote satiety by acting at the level of the brain also. So the GLP has these additional effects, and by promoting the rise in endogenous GLP, we could get some additional extra glycemic effects of these DPP-4 inhibitors. And the major effect is that the insulin secretion which is happening is a glucose-dependent insulin secretion, and therefore the risk of hypoglycemia is much less as compared to the other insulin secretagogues which do not have this glucose-dependent insulin secretion, which are more potent than the DPP-4 inhibitors, but they have the non-glucose dependent secretion, so therefore insulin secretion, so therefore they have a higher risk of hypoglycemia. So and it is expected that we were discussing about beta cell exhaustion. So I would like to state here that this beta cell exhaustion is only a concept which has been promoted for the introduction of these drugs, but I would say that this has not been proven anywhere. The beta cell the exhaustion theory has not been proven anywhere. If you look at long-term data from the Wikipedia study, or if you look at the advanced study, you would see that even after several years of diabetes, these agents like the sulfonylureas have been shown to have their efficacy even at 10-15 years of diabetes itself. So, because the advanced study was enrolling patients who were already having 9 years of diabetes and another 9 years of follow-up, 9 to 10 years of follow-up. You find that they had diabetes for about 15 to 16 years, and they still continue to maintain, reach the glycemic. They were at less than 7 HbA1c maintained, and less than 7 HbA1c or 6.5 maintained with the use of either glimepiride there or the use of glycoside in the advanced study, showing that the efficacy in terms of HbA1c reduction was maintained even at 10 to 15 years of diabetes, showing that this concept is not definitely proven. In fact, there was one study which has come out very recently questioning the ability of the GLP-1 analogs in terms of preservation of beta cells. In fact, they're showing that there is initial stimulation of beta cells followed by reduction of beta cell mass, which has been again shown in a humanized rat model. It's not exactly human cells, but it's a humanized rat model. So both the sides of the story are known. Now, let us see the efficacy of these DPP-4 inhibitors. I've just shown you how they work. Now, if you look at the efficacy, you find that this efficacy has been, they have a long duration, they have a good efficacy which maintains over a long period of time. And what we find is that they bring down the HbA1c to the extent of about 0.7 to 0.8% as monotherapy. And in combination with metformin, they bring it down to as close to about as much as about 1.5 to 2% also. As you see here, it's about 1.4% reduction over a 1 year follow-up with metformin when it was used along with metformin, beta-glucan along with metformin. And at 2 years also, it was same again, a reduction of more than about 1.5, close to 2% reduction. That is when it is used along with metformin. And as a monotherapy, the reduction is to the tune of 0.7 to 0.8%. So this again shows the comparative efficacy of different drugs. Sulfonylureas close to 1% or maybe more than 1% also. Glinides again 0.7 to 1%. PZD is 1% reduction in HbA1c. AGIs bring down to a modest 0.6% reduction. DPP-4 inhibitors are about 0.7 to 0.8%. So comparatively, they are little less effective as compared to the sulfonylureas, but comparable, or even the glitazone, but comparable to them. And if you look at this again, looking at different combinations that they use, along with combination of metformin or combination of sulfonylureas, you find that they have a relatively good efficacy in terms of reduction of HbA1c. Now, if you look at the different components, you find that they cause less of weight gain, they cause less of hypoglycemia, and less glycemic variability. And they have additional benefits beyond this glycemic control also, as we discussed. So this is comparing the rates of hypoglycemia of different drugs, and we find that the DPP-4 inhibitors score out as compared to the other drugs in terms of causing less hypoglycemia. As you see there on the right, extreme right, you find the DPP-4 inhibitors, the risk of hypoglycemia with as compared to other OADs, you find that the risk is higher with sulfonylureas. This slide surprisingly shows that glenoids have a high risk, quite a significant risk of hypoglycemia, which was not what we were speaking of in the earlier presentation. Okay. So if you look at typical comparisons which have been done between add-on of to metformin of sulfonylurea versus a DPP-4 inhibitor, I have shown that you have almost similar efficacy with much less weight gain with the use of a DPP-4 inhibitor as compared to sulfonylurea. Sulfonylurea also has the same efficacy, but it produces more weight gain and more of hypoglycemia as compared to the DPP-4 inhibitor. So this is the weight gain. You find that these drugs are weight neutral, while the other drugs can cause weight gain. The sulfonylureas and glenoids can cause weight gain. EZDs actually cause, or the glitazones, as we know, that is the pioglitazone, which we are speaking of most of the time, causes more weight gain than these other drugs. And the AGAs can actually cause a little weight loss also. So, and then coming to the durability, as was shown in the earlier slide also, this durability was seen with the gliptins for the 2, and now we have some 4-year data with some of the gliptins, because they are now been there for about 8 to 10 years, but we have about, I think, at most about 4 to 5 year data with different gliptins. And if you look at the quality of life, if you look at different parameters in terms of quality of life with regard to the hypoglycemia being less and weight gain being less and all that, so you find that they have actually a good impact on the quality of life as assessed by different questionnaires. Now, if you compare different gliptins, it is if you look at the different gliptins, you've got sitagliptin, vildagliptin, saxagliptin. Allogliptin is not yet introduced in our country, but it's available in Japan and many other countries. Linagliptin is also available. So we have 4 gliptins, and then we have the other gliptin, that is teneligliptin, which is recently come into the market. So teneligliptin is also a Japanese molecule which is studied in Japan and some other countries, and the amount of data that is there is probably little less than the other drugs. And so this comparison has basically these 5 gliptins. And what we see is that they have looked at the different selectivity of these gliptins, and all of them have more or less good selectivity, and some of them score out over the others in terms of selectivity. Linagliptin probably has a good selectivity, vildagliptin also. So most of these drugs have a better selectivity for the DPP-4 as compared to DPP-8 and DPP-9, and therefore they are effectively introduced as medications for control of hyperglycemia. And if you look at the duration of action, they have differences in their duration of action. Linagliptin has a long duration of action, sitagliptin followed by sitagliptin, and vildagliptin and saxagliptin have shorter duration of action, but they have longer binding to their receptors. So most of them are once a day, except vildagliptin, which is twice a day, and teneligliptin is also once a day. Then I would like to just highlight on some issues, like if you look at the pharmacokinetics of these drugs, of these different agents that are available, you find that if you look at their use in renal impairment and hepatic impairment, what we find is that the dose needs to be reduced for renal impairment. They have to be they don't require much of dose reduction in hepatic impairment. But if you look at renal impairment, most of these drugs require a dose reduction by 50 to 75%, whereas for linagliptin there is no need for any change in the dose requirement. And teneligliptin also has similar sort of pharmacokinetics as linagliptin, having 50% hepatic and 50% renal excretion, and therefore that also has been said not to have a requirement for reduction in dose in terms of renal in patients with renal failure. So having looked at that, I think they can even be added on to insulin, as we have seen different studies which have shown, which have looked at adding gliptins to insulin, sitagliptin and sitagliptin, and then the issue of cardiac safety has been also looked at, and we have data from these the phase 3 studies which have been pooled together. We have that data from a long time, but the other issue is that we also have some of this data available. We have data from the TCOS study and the SAVOR-TB study for saxagliptin and TCOS study for sitagliptin, which have shown that they are neutral. They have neutral effects, that they do not increase the risk for any cardiovascular outcomes. They do not, they are safe from the cardiovascular point of view, although they may not have any advantage from the cardiovascular point of view, but they do not have any risk from the, they do not increase the cardiovascular risk in patients. And we are still awaiting the results from the Karve study. So as Dr. Anupam also has shown the data on the sulfonylurea also. There was a concern with the UGTP study that there was some adverse cardiovascular outcomes with sulfonylureas, but that has subsequently been clarified in the recent studies. And now we have data from the gliptins also. None of them have been shown to have any cardiovascular adverse effects. They are also shown to be cardiovascular neutral. And then coming to the SGLT2 inhibitors, we may find some difference in the outcomes, which was mentioned to you yesterday by Dr. Munjal also. I will just speak about those also. But if you look at the safety in terms of, I think I've already finished this, so I'll not go into details of that. So I think that is basically what I would like to say about the incretins. The DPP4 inhibitors is that they have efficacy which is comparable to sulfonylureas, maybe a little lesser, but comparable to sulfonylureas, with additional benefits of causing less hypoglycemia, less weight gain, and having a durable glycemic benefit without having any cardiovascular adverse effects. And because of the fact that they have low risk of hypoglycemia, they are also suitable for use in periods of fasting, like this study have looked at using them during the Ramzan period, and they have shown that either sitagliptin or vildagliptin have been shown to have some benefit in terms of causing less hypoglycemia. So they cause good glycemic control, reduce glycemic variability, negligible hypoglycemic weight gain, and provide a better quality of life. Now coming to the SGLT2 inhibitors. SGLT2 inhibitors are basically working through decreasing the glucose excretion through the, are causing increased glucose excretion through the urine. The SGLT2 inhibitors, normal, if you look at the normal physiology, there is 180 grams of glucose going through the kidney every day, and this is being filtered out. 180 grams of glucose is being filtered out, and most of it is being reabsorbed. And only about 0.5 grams, less than 0.5 grams of glucose is going out in the urine. The reabsorption is very effective in terms of 179 grams of glucose being reabsorbed, and this is properly enhanced in patients with diabetes. And so we have this SGLT2 inhibitors which are inhibiting the SGLT2, which is present particularly in the S1 segment of the proximal tubule, and which contributes to 90% of this reabsorption. So this concept came in because of the fact that there is the observation made in patients who have got renal glycosuria, who have absolutely no problem, and they are absolutely normal, even though they lose a lot of glucose in the urine. And based on that observation, these inhibitors of these SGLT2 transporters were developed, and these work in the proximal tubule, and they inhibit the reabsorption of glucose from the proximal tubule. So what is their role? They are increasing the SGLT2 excretion. In diabetics, what we see is that there is alteration in glucose control. There is increased gluconeogenesis in the kidney. This is contributing to a threefold relative increase is happening in patients with diabetes. Apart from that, the glucose reabsorption is also enhanced in patients with diabetes. So we have these SGLT2 inhibitors, which are acting by inhibiting these transporters, they cause reversal of the glucotoxicity, and they inhibit. They are working through a mechanism which is totally independent of the insulin secretion, and they are suppressing the gluconeogenesis, increasing the insulin sensitivity in the liver, increasing the insulin sensitivity in the muscle by reversing the glucotoxicity, and they are improving the beta cell function. So all the benefits that they are producing are because of the fact that they cause reversal of the glucose toxicity, and they are working independent of insulin action and beta cell function. They are effective at all HbA1c levels, and they can complement with any of the other OADs and with any of the injectable preparation, that is with the insulin also, and they have effects beyond glycemic control, that is in terms of causing weight loss and reduction in blood pressure. So these are the two additional benefits that they provide in addition to reduction in the glucose levels. So they inhibit, so as I said, this therapy is simple and non-specific. They do not, they cause a decline in plasma glucose levels and cause reversal of glucotoxicity, and they complement with any of the oral drugs that are available, and also they are even effective in patients who are not responding to other drugs. So they respond to the SGLT2 inhibitors, and the ones which are available are these three, that is dapagliflozin, canagliflozin and empagliflozin. All the three are approved in our country, and empagliflozin is particularly used in Japan, not yet approved, is not widely used in other parts of the world. And study to date have shown that they are good as monotherapy and as add-on to metformin, SU or TZD or DPP4 inhibitors, or as add-on to insulin. They are used once daily dosing, and the extent of HbA1c reduction is to the tune of about 0.7 to 0.8%. Weight loss is about 1 to 3 kgs in addition to the reduction in HbA1c. And the major problem is that they could cause genital infections because of the high amount of glucose being lost in the urine. So that has to be looked into, and that can be a sort of limiting factor in some patients. So the pleiotropic benefits are there in terms of BP lowering, weight loss, and reduction in albuminuria. And if you look at different studies which have looked at the SGLT2 inhibitors, particularly I'm just showing you as an example dapagliflozin. You find that as monotherapy or as add-on to any of the drugs, they have brought about a reduction in HbA1c to the tune of about 0.7 to about 1.2%. And this is sustained over a period of time, and this is 2-year data showing that this effect is sustained, and they cause reduction not only in the fasting plasma glucose but also the postprandial glucose levels, and they have the reduction in body weight is also sustained over a long period of time. And if you look at what is the weight that is lost, as we were discussing a lot about the weight in the morning, we find that the major portion of the weight that is lost is the fat mass which is lost, and the fat-free mass is maintained, that is the lean tissue mass is maintained, while the fat loss is seen with the SGLT2 inhibitors. And the reduction in blood pressure is also shown, and these are sustained over a period of time. So this provides a novel mechanism of action. This group of drugs provides a novel mechanism of action. No hypoglycemia as a monotherapy. They cause weight loss. They do not require titration of dosing. So as compared to the other conventional drugs where titration of dosing is done, here and with the DPP4 inhibitors, you don't require titration of drugs. They are reasonably well tolerated, and there is a possibility of use in type 1, but again that is something which has been a concern because of the fact that there was some cases of euglycemic ketoacidosis reported with the SGLT2 inhibitors. And the other issue that has been noticed is the issue about loss of bone mass, which could aggravate the risk of fractures, which has been seen with canagliflozin in particular. So I think finally what I would like to end with is that saying that you need to choose a particular agent based on the pathophysiological abnormalities, the efficacy of these drugs, the safety, the cost of the drug, and what is the outcome data available. So this is how the ADA-ESD algorithm suggests that you would choose a drug based on 5 parameters, that is the efficacy, the risk for hypoglycemia, weight, the effect on the weight, the side effects, and the cost. So this is how you would place all these drugs. After metformin, you have a choice of all these drugs. You would either choose a sulfonylurea or a gretazone or a DPP4 inhibitor or a SGLT2 inhibitor, depending on these 5 parameters. So I will not sort of, I think I'll close here with this slide, which actually gives you a good idea about where these agents are placed and how we decide which agent to choose after metformin. Thank you. Yeah, they have a beneficial effect in terms of reduction in blood pressure, which is modest, maybe about 5 to 7 millimeters of mercury may be seen with these agents. And as we were showing yesterday, data from large studies that even 4 millimeter or 6 millimeter reduction in blood pressure does bring about a long-term benefit. And probably that's the reason why we have seen that we had this empowered study showing that the cardiovascular benefit is there with these drugs as compared to all the other drugs which have been studied, which have shown a cardiovascular neutral effect, whereas this drug, that is empagliflozin, has shown a 30% reduction in cardiovascular outcomes, as was shown by drugs.
My question is
Hypo, that is blood pressures are low. Okay, no, I mean that again depends on what the scenario is, how much is HbA1c is raised, and I would, if a lean person who is as per what you're saying, he's lean and his blood pressures are also low and all that, he probably is a candidate who requires insulin rather than using a drug like this. So I would look at his other background history, that is how long he's been having diabetes, what is his. Generally, a person like that, what you're describing is an insulin-obedient person who requires more benefit from insulin use rather than using glucagon.
I would be better.
Yeah, maybe. But if he's significantly insulin deficient, I think insulin is the best form of therapy there.
Dr. Sahib, one last question. Yeah, please.
We should remember one dictum that if the patient loses weight and develops low blood pressure with oral hypoglycemic agents, the answer is only one. Let us be practical and candid. Then insulin is the drug of choice, and we should use only insulin. As Professor Sai also said, the only point I am making is that to reiterate and reinforce. Let's make a rule of thumb so that it becomes easier. That if you are losing weight, please try looking after the other causes of weight loss. If they are not there, then please use insulin.
Dr. Sahai, there is a noise level nowadays. Pioglitazone increases weight and SGLT2 decreases weight. So is there any rationale of the combination of the two? And how much dangerous it would be to use both together?
Combination of the two.
Pioglitazone and SGLT2 inhibitor.
No, that's what I'm saying is that in a person who probably is going to benefit from the use of pioglitazone is somebody who has got early onset of, is early in the course of diabetes. He has well-controlled pioglitazone. I think that sort of person doesn't require an add-on of SGLT2 inhibitor. And if he's, I don't see much of a rationale in that
Both these
combination.
drugs have potential carcinoma.
Yeah.
That's what I'm asking.
Yeah.
They both have potential, though they have been cleared to some extent, but one drug was well down acidity for the same reason, and I also had some doubts that
Probably you can use that.
And
That
also bone fractures.
added reason for not for combining those two, but I don't see any pathophysiological mechanism where they would benefit such patients also. Yeah, so I think I'm looking at the side effect profile. I think you should avoid those two.
And so regarding the SGLT2 receptors in the heart, is there any good effect or bad effect by inhibiting them?
Well, SGLT2 receptors in the heart, I don't think much is known about them. Yeah, they're there in different places. But what would be their, what would be the actual effect of the SGLT2? Probably that's going to be beneficial only because we have seen the empiric study which has shown a good outcome. So I think going by the results of the available studies, I think they're
benefits are just not for blood pressure only. It is something different than that. Still they don't know again, but I think in cardiac there is some effect probably, and that's the mortality rate of 24% in heart failure coming. And something surprising to even the investigators are not expecting that and they got it, but there is some other mechanism at the cardiac level or at some level, the other receptors are working, and that's the answer to it.
To add to the discussion of SGLT2 inhibitors, as a nephrologist, they are much talked about in nephro circles now, and it is thought that they are as good or may prove to be as good as AC inhibitors. And the main cause of nephropathy is the intraglomerular hypertension. And it's thought that the ACE inhibitors act on the vessels, the preglomerular vessels, and they reduce the blood flow and in the glomerulus and decrease the intraglomerular blood pressure. And these drugs, SGLT2 inhibitors, they also decrease the intraglomerular blood pressure, but they act on the postglomerular vessels and by a mechanism called tubuloglomerular feedback. So it's thought that combination of ACE inhibitors and SGLT2 inhibitors would provide renoprotective benefit to the tune of 38%. 19% contributed by ACE and 19% by SGLT2. But time only will tell, and credence study is also underway to prove or disprove this point.
And again, we have to see the eGFR levels, because all the drugs, all the SGLT2 drugs cannot be used in all eGFR levels.
True, that's why the credence study includes those patients where the GFR is as low as 30. As of now, they are cleared for use for GFR more than 45.
Thank you, Dr. Sahai. Thank you, Dr. Munjal. I'd like to close the session and go on to the next session.
I request Dr. Sahai to present the memento to Dr. Rishad Ahmed and Dr. Reddy.
तो मिल गया
Proceeding for the next session, insulin of cornerstone of diabetes management. I request Dr. Aditman Prakash.
In type 1 diabetes and type 2 diabetes with pregnancy and intensification of insulin. Dr. Anu, thank you.
Thank you, sir. Dr. Munjal just already said that whenever in doubt, you start insulin. So I don't think the symposium title also is insulin the cornerstone. Insulin does remain the cornerstone. And again, I would like to thank these chairpersons also, and we'll try to finish it well within time. So we all know about this natural history that one of the main problems that we have in a diabetes patient is that there is progressive beta cell failure. And once you have a progressive beta cell failure, and as Dr. Sai also said, once you do not have any drugs to actually halt or revive the beta cells, because they are all named drugs, you do not know actually what exactly will unfold over the years. So insulin remains the choice. So I don't think I will well into this, but insulin today is one of the most studied proteins. It has 3 Nobel Prizes awarded to it, and it generates today as much excitement as it generated when it was discovered. So again, as our institutions are completing 100 years, this molecule is also now 95 years old. But still, it is young because we are still at it and we are trying to decipher new things. The next 2 talks will tell you how new things we have. So now coming to insulin, for whom it is intended. We all know this, whether we should use it for all diabetics. There is one concept of early insulin initiation. I have it with one of my slides. So do we need to give it to all diabetics is one of the big things. But yes, type 2 diabetics we still tend to hold. As yesterday Dr. Munjal said, clinical inertia. That clinical inertia is very well with insulin also. Even those patients who deserve to be initiated on insulin, we do not initiate. We try to postpone. Not only patients but doctors as well. So do we need a selective flow? Or it depends upon the viewpoint fancies of the doctor. So obviously neither of these 3 is correct. We do have clear-cut indications, type 1 diabetics, all insulinopedic patients. Type 2 diabetes, now this was what was their primary or secondary failure. We used to, as Dr. Sai said, that we used to think that proteinuria caused beta cell failure. But in UKPDS, it was found that 5 to 10% of all type 2 diabetics would fail, which was actually alluded to as secondary OHA failure rather than secondary sulfonylurea failure. So even patients who were receiving insulin sensitizers like metformin, they failed at the rate of 5 to 10% also. This was seen in UKPDS. That is why it was changed to primary sulfonylurea to primary or secondary OHA failure. So body very small group requires insulin, and yes, insulin is definitely required for persons who need a tight glycemic control, like gestational diabetes, post-renal transplant, diabetic nephropathy, post-CABG patients. These are the groups where obviously insulin could be the sine qua non. So acute, just like I will just run through this because we know that acute complications you should not put patients on any other drugs, just add insulin. Once the patient recovers, you may put back to other oral drugs. So perioperative and emergency. These are the things. So when to start? So this is what, as I already said, once you think that beta cell failure is progressive, you need to be cautious and you need to start. And this is what I just alluded to. 5 to 10% patients will fail every year. That means 5 to 10 years time, most of the patients should be on insulin. But as our Dr. Sahai said that sulfonylurea is also, some patients will continue to be on sulfonylurea 15 years. So there is some genetic component or some environmental variable which still the progression of the natural history of diabetes is not uniform in all patients. So there does exist a concept of early insulin initiation, and although it has been a little controversial, but whatever studies have been there, they say that if you start insulin early, you can give beta cell rest and you can preserve the beta cell mass for a longer time. It does lower insulin requirement for a period up to 2 years. It delays the complication. So this is probably the concept now that has come of legacy effect, which was talked about yesterday also by Dr. Munjal, today also by Dr. Sahai, that if you control the blood sugar early, so obviously insulin is the best tool to control blood sugars early. So if you control them early, probably you will delay complications also. This could be a vital advocate of early insulin initiation. So patients who are young, obviously, and non-obese, as already just the last discussion, insulinopenic patients type, you may be justified in starting them on insulin. And those who have severe symptoms, these are the patients like this was discussed last time. These are the patients who should not have any doubt, you should just put them on insulin. The other obviously the category becomes soft OHA failure, so those patients will need to be. So there are 3 concepts now: early insulin initiation, if you want to give, you can try those patients who are severely hyperglycemic, young patients who are non-obese type 2 diabetics, and patients who are failing on oral hypoglycemic. So how do you start insulin? That is probably initiation and intensification. So these drugs obviously I am not going to discuss because the next speakers would say they are in their domain. But we need to identify that we have these time profiles, the insulin time action curve, which we need to understand, and depending upon what the patient is consuming as in the morning, we need to put them on these insulin. So we have the rapid, the short acting, the intermediate acting, and the long acting insulin, the glargine, intermediate, and now distributed. And this is the physiological insulin release. So there is a basal release, insulin is released in pulses of 15 to 60 minutes throughout the day. And whenever we intend to eat anything, we have these spikes. So we need a basal insulin to cover those basal insulin release, and we need to cover these spikes. The food that we eat, they need to be covered. So we need a basal and bolus injection. So a basal injection maybe 1 or twice a day, and a bolus injection whenever we need to take. This is the basal bolus regimen. And the second is the premix. So we tend to combine the slots of this intermediate acting insulin with a short acting insulin to minimize the injection. Because if we are using a basal and bolus regimen, then basal dose may have to be at 1 or twice a day. And suppose the patient is having 3 meals, then it becomes 5 injections, 4 or 5 injections. So in a premix, we try to give 2 injections to the patient, combining the intermediate acting and the short acting. So this is what we try to give the basal bolus regimen on the top. We give 2 injections of the basal insulin or intermediate acting insulin and 3 injections of the bolus regime. And in the below diagram we see 2 pre-mixed insulins. So these are short acting and intermediate acting insulin twice a day. So whenever we start the earlier, again talking of the old area, I always refer to it, is the BIDS regimen, the bedtime insulin, daytime sulfonylurea. So if you add a patient who is on, a patient who has developed secondary HFAD, you want to start an insulin, then you just add a single dose of maybe basal insulin or an intermediate acting insulin to this patient if the fasting plasma glucose is high. And what you can do is, if the fasting as well as BP is high, then you add a premixed insulin. So this is the, I will just come to that slide a little later. But the fixed dose combination has its advantage. It takes care of both fasting and BP plasma glucose and easy desiccation from twice to twice if possible. Otherwise, you need to give more injections to the patient. Patient has one insulin, one device, so you just add single, twice daily, thrice daily, that is premix. So single dose regimen, as I said, single daily injection, intermediate acting insulin or basal insulin before breakfast or HS. This is the single dose regimen. So I also already alluded to BIDS regimen, the bedtime insulin, daytime sulfonylurea regimen. So daytime OHS you can continue, just add a small dose of 8 units or 10 units or 12 units of basal insulin to that patient. Basal insulin or intermediate acting insulin. The other is you can add a single daily injection of biphasic or a premixed insulin. So these could be any of these, mixed regular or NPH insulin in various combinations depending upon what component is high. So control of fasting plasma glucose is critical. Bedtime NPH insulin treatment for this purpose is especially used. Now we have other agents like basal insulin which can be for 12 hours or 24 hours. So you can add basal, glargine or Degludec at bedtime or Detemir at bedtime. So that is the conventional thinking that we usually have. For control of postprandial glucose excession, insulin analogs have been shown to be effective, and you can just add a shot of this thing or add a premix if the postprandial is also high. So if the blood sugar is not controlled on a single dose of premix or intermediate acting insulin, then you come to twice daily regimen. So this is what is intensification. You increase from one dose to the other dose. So twice daily you can use NPH insulin, these are the agents, or you can use a mixed regular and NPH insulin twice daily, or you can use a biphasic insulin before breakfast and before dinner. So we need the charger of the laptop. Dr. Manisha. So more intensive regimen, you will require a multiple subcutaneous insulin infusion or a CSII, which obviously we usually do not use in diabetics. I will leave this disadvantage. Yes, this is the one. So just to see, premix once daily start, you can start as a basal dosage. This is single injection. If the patient is not controlled, you get an HbA1c done after 4 to 8 weeks or 8 to 12 weeks to see. If the HbA1c is still high, more than 7% or 7.5%, you intensify. So you shift from premix once daily to premix twice daily. If again after 8 to 12 weeks you find the HbA1c is still high, it is not controlled, then you shift to premix 3 times daily. This is what is intensification. And the other arm, the basal bolus arm, what you can do is you can start with a basal insulin at bedtime or maybe in the morning, because now 24 hours insulin are available, and then you can add a bolus dose before breakfast once you find the postprandial is high. And alternatively, again you can use another injection of a short acting drug, which will be now 4 injections. So 1 injection of basal. If it is not controlled, add a bolus before breakfast or before lunch or before dinner. Then you can keep on adding after every meal whenever you want to control. So this is intensification. So it is always, we always prefer the premix one, OD, BID or DID, because it minimizes the injections. The medication is one. The patient has intermediate acting insulin which is to be used, and again you can just intensify them. On the contrary, in basal bolus, the control is easier to achieve because you know you are giving a basal insulin, and then you can have short acting insulin before meals. So at times we need to use basal bolus patients who are in emergencies, and then we can, once the control is achieved, we can shift to a premix insulin on the most approximate. I think we can invite questions because that is the basic, because the other two lectures will be more elaborate. I was just trying to sensitize you on initiation and initiation. There is not much initiation.
Thank you, Dr. Anupam. Thank you, Dr. Anupam. We will be taking on questions at the end of the session. Yeah. Thank you. So, so I would like to invite Dr. Rakesh Sahai. He will be giving a talk on rapid acting insulins. Dr. Sahai, please.
So I think taking forward from where Dr. Anupam has left, he has given us the importance of insulin in patients with type 2 diabetes, that most of our patients with type 2 diabetes eventually require insulin. Apart from the fact that every patient with type 1 diabetes requires insulin, most of our patients with type 2 diabetes require insulin at any point after a certain duration of diabetes, and he has given indications for using insulin early in patients with type 2 diabetes, also right at the time of onset, also they may be requiring insulin also. So now coming to the problems that are there with the conventional insulins, he has shown us that insulin has evolved over a long period of time, from the 95 years since the time it has been discovered. In the early 60 years, the first 60, 70 years were spent in making purified forms of insulin, making the human insulin itself purer and having less impurities. That was the initial phase of development. And then the second phase of development, what we have realized is that there are certain other problems which are there with insulin. That he has highlighted that he has described the physiological insulin secretion, where there is a constant basal secretion. In addition to that, there is a prandial insulin secretion in response to a meal. And this is again in two phases. The first phase of insulin secretion, which happens early, and the second phase, which is a little more prolonged. And so what we find is that there are some challenges with the available conventional insulins. And those challenges are that there is a mismatch between the glycemic excursion between the insulin release following the injection. And therefore there is this postprandial hyperglycemia that happens. And that is something which is a challenge to manage even with insulin. And there is a delay in insulin absorption after its injection, poor postprandial control because of that. Poor fasting control is also there, and towards that end we have the basal analogs about which Professor Munjal is going to speak. And there is a lack of true basal insulin. Hypoglycemia is quite common even with the use of insulin. We all know that insulin is the most potent agent, and therefore there is a higher risk of hypoglycemia whenever there is a mismatch between the insulin requirement and the timing of insulin release. And excessive weight gain also happens with insulin. So these are the challenges that are there with insulin in the conventional insulins. And so therefore we have come out, the changes, the structure have been made to come out with better insulins. So what is happening is that there is this, the timing with which insulin is released is the most important key, and that's the reason why we are having these analogs which have been developed. The timing is the most important part, as you will understand as we go along in this lecture and the next lecture. The timing of insulin release is very important. So we see that there is a constant basal insulin secretion, and in addition there is a first phase of insulin secretion initially, and then there is a release, a more delayed second phase. So we need to have this insulin available. When we inject insulin, it should be available at that time, but most often that does not happen with the conventional insulins. So if you look at this picture, what you see is that this is what we require. The blue line is what we require. We require a constant level in the body. In addition to it, whenever we have a food, there needs to be an immediate release of insulin is required, and that does not happen with the conventional insulin that is secreted. That is the yellow line. Yellow line shows the conventional insulin. So when you inject conventional insulin at the time of the meal or a little before the meal also, what you find is that it does not provide the peak that is required, and the peak, even if it is there, it comes a little later. and it comes a little at a time when insulin is not required. So you see that there is a gap between that blue line and the yellow line. Later on, when you see, there's a pointer here, but if you see after 2 hours after the meal, the blue line, that is physiologically the insulin secretion would be shutting down then, whereas here the insulin is continuing to act at that time, and that's the time when hypoglycemia can occur. And initially, when this yellow line is falling short of the blue line, the insulin requirement which is there is required at that point of time is not met. So therefore, postprandial hyperglycemia is a common problem in many patients with diabetes. So to overcome this, we need to sort of look at how we can modify the timing and provide more insulin at the time when it's required. And for this end, towards this end, and why is this happening? Why is this delay happening? Is because of the fact that when you inject insulin, it aggregates. When you inject into subcutaneous tissue, insulin, as you know, has a structure of 51 amino acids, 21 amino acids in the A chain, and 30 amino acids in the B chain. These are linked together with disulfide bonds. And when you inject this insulin, it is in the form of a monomer. But then when it is going into the subcutaneous tissue, it forms dimers and hexamers. And these hexamers do not allow the insulin to go into the capillary bed immediately. And these hexamers have to be broken down, and that happens over, say, about a half an hour of time. And that is required for these hexamers to break down and then the insulin to enter into circulation. So this delay is what is causing the delay which we are seeing. And to overcome this delay, there have been some changes in the structure of insulin which have been made. So this insulin aspart is one of the insulins where there is one change done at the B28 position. And because of that, this self-aggregation of insulin is prevented. And this is rapidly absorbed even after injection into subcutaneous tissue. And similarly, other changes have been made, like all of them you see that there are changes there only because that's the point where the aggregation happens. And you see that in Lispro, the lysine-proline sequence is changed to proline-lysine. And that is what is Lispro. And it also is very rapidly absorbed. And then you have a similar change done in blue-lysine also. And so that also prevents the aggregation. So this is how the change in structure of insulin is made to prevent its self-aggregation in the subcutaneous tissue and its faster absorption into the bloodstream. So what we find is that all these insulin analogs, we need to look at how is their affinity towards the insulin receptor, because we are changing the structure, making a little change in terms of their pharmacokinetics, but does it affect their receptor binding, and does it affect their metabolic potency and its mitogenic potency? These are the issues that have to be considered. And these analogs have been developed after looking at several analogs which have been rejected because of the fact that some of them were not having their metabolic potency or had more of mitogenic potency. So this is just to show that most of these analogs which are available today have similar sort of metabolic potency. So now let us look at the pharmacological profile of this analog as compared to rapid-acting analog as compared to the regular insulin. You find that the orange line is the one which is showing the rapid-acting analog, which after injection is having a peak, having an onset of action within 5 to 10 minutes, peaking at about half an hour, and then lasting for about 2 to 3 hours. Whereas the human regular insulin is in the gray, and which is showing a poorer peak, and the peak which is happening much later, and which is sort of not lasting much longer than the rapid-acting analog that we see. So this is how the profile of insulin is shifted towards the left, with a more pronounced peak acting occurring earlier. And that makes the difference in terms of causing less of postprandial hyperglycemia, and so therefore it is particularly useful in patients who have the indication for using this type of insulin is in patients who have got severe postprandial hyperglycemia, and also those who have got late post-meal hypoglycemia also. So if they have delayed hypoglycemia 4 hours after a meal or before the next meal, if somebody is having hypoglycemia, it means that the regular insulin taken in the morning has its effect, has a prolonged effect, and that needs to be modified by using a rapid-acting analog which may provide that benefit. So if you look at their PK/PD differences, these are listing out the PK/PD differences, showing that it has a faster onset of action and a with diabetes, type 1 diabetics in children where it is difficult to predict whether they would eat a meal at a particular time. So otherwise, when you use a regular insulin, you use half an hour before a meal, and you expect the person to take the injection half an hour before the meal and take the meal after half an hour. So then he gets the best profile of insulin that he's using. So in children, what happens is that this can be an issue in terms of their prediction of whether they would eat or not. So in such situations, it would be good to use insulin after the meal. So after they have taken a meal, then you could give injection, and you could expect if it got a similar kinetic as would be produced by giving the injection half an hour before a meal, a regular injection. So that is a situation where it is going to be useful. So we were discussing about this patients with type 1 diabetes. These studies have looked at the glycemic excursions that are happening with the injection of regular insulin versus the rapid-acting analog. And you see that with the rapid-acting analog, the excursion is much lesser. The post-prandial glycemic excursion is much lesser. And when you look at overall data in terms of finally, okay, the post-prandial glucose levels are coming down, but is it giving an impact on the HbA1c level? Because we know that HbA1c reduction is going to bring about benefits in terms of reduction of complications. So is that hard endpoint also seen? So towards that end, they've looked at looking at HbA1c reductions in patients with type 1 diabetes, and you see that and this is comparing between type 1 and type 2 diabetes. You find that in patients with type 1 diabetes, at least all the curves are towards the left. On this forest plot, you find that all these means are on the left side, showing that they are favoring the use of insulin as part. Whereas in type 2 diabetes, you don't find that benefit. So type 2 diabetes probably does not benefit that much from the use of insulin as part, as much as type 1 diabetics definitely would show more benefit in terms of reduction in HbA1c levels. And if you look at the long-term benefits, you find that in terms of the HbA1c reduction, this is a study which is looking at 3 years of use of regular insulin versus aspart, and we find that there was a benefit in terms of reduction in HbA1c to the tune of about 0.5% or little less than 0.5% reduction in HbA1c over the 3 years of follow-up. So is it safe in patients in terms of causing less hypoglycemia, less adverse events, whether it has an effect on cardiac repolarization of insulin antibodies? These are potential issues that we have to look at. So if you look at the risk of hypoglycemia, there was a 72% lower risk with the insulin aspart as compared to regular insulin in terms of causing nocturnal hypoglycemia. Diurnal events were not different between the two, and total events were also slightly lower with the aspart, but not statistically significant. But the major benefit was in terms of nocturnal hypoglycemic events. And then if you look at major nocturnal hypoglycemia, again in type 1, type 2 diabetes, you find that it's better with in type 1 diabetes. There is a benefit in terms of reducing nocturnal hypoglycemic events. And now in terms of dosage timing, as we were discussing earlier, that you could see the benefit in terms of having a very rapid onset of action and better treatment satisfaction in people. Particularly this is useful in children, pregnant women, elderly patients, and those with renal lymphatic infections. So these are the four subsets of people who are going to benefit definitely from the use of rapid-acting analogs. So as I was mentioning, it is also approved for use in these situations: the elderly patients, the pregnant lactating mothers, and children who are aged 2 years or older, and special population with hepatic and renal impairment. So these are the conditions where it's going to be useful, and there are studies on that. I will just project a few studies just to show how they are useful. This is in terms of children, where you find that there is a better profile seen with the use of a post-meal analog. So as compared to a pre-meal regular insulin versus a post-meal analog. So as I was mentioning, that in children where it is difficult to predict their food intake, so you give it post-meal also, you will have a similar profile as with or a slightly better profile than pre-meal regular insulin. So that is the benefit you can achieve in children. And in pregnancy also, what we also know is that the postprandial hyperglycemia is the major issue in pregnancy. And so in such situations, if you use analog, you may find a better control of postprandial hyperglycemia, and you find that there are lower rates of hypoglycemia also in pregnancy with the use of aspartame and log. And then if you look at hard endpoints like live births, fetal loss and fetal deliveries and all that, you find that there is a benefit in terms of using aspartame as compared to the regular insulin. And generally you have reserved pharmacokinetics as you would expect in younger people also. You have this peak and you have this action which is not lasting for more than 2 to 3 hours. So you get more benefit with the use of aspartame elderly also. Now in patients, the renal impairment also it has been studied and it has shown that its pharmacokinetics are reserved in patients with renal impairment, because here your main problem with the renal patient, the renal impairment is the development of hypoglycemia frequently. So if you are having an insulin which has similar pharmacokinetics and the hypoglycemia that is happening in renal failure is because of the prolongation action of some of the drugs, particularly the oral agents have a prolonged action, and sometimes even the regular insulin has a prolonged action as much as NPH insulin. So with I'm concluding. So with aspart, you have this benefit of having reserved pharmacokinetics, which sees that they don't have a prolonged action of insulin. And then the other issue is that even in the ICU and non-ICU settings, it can be used because it can be used as the preferred insulin because it has an advantage of not causing controlling the postnatal hyperglycemia, and at the same time it has been studied whether it could be used intravenously also, and it has been shown that it can be used intravenously also without change in the pharmacokinetics, and therefore it can be the only insulin that is used, that is right from the time when the patient requires IV insulin to the time can be shifted to subcutaneous insulins. So you could do a transitioning also without requiring much of a change. So what we are saying is that by changing when the cost is not a major issue in the patients in whom cost is not a major issue and where you want to have the additional benefits, you could benefit by producing significantly lower HbA1c and glucose and lower glycemic excursion with the use of rapid acting analogs. You could reduce the rates of major hypoglycemic episodes in patients with type 1 diabetes particularly, and you could provide flexibility and convenience in meal-time dosing, and it could be used in a variety of settings such as renal failure, pregnancy, and in the ICU also it can provide a simple transition from IV to subcutaneous insulin. So these are the benefits of using a rapid acting analog wherever it can be, wherever these problems are there. So I think with that I will end, and I think we'll have the questions later.
Thank you, Dr. Sai. Now, I think question and answer will be taken in the last. And first, I will ask Professor Munjal to start his talk on basal insulin. And the audience is advised to put their questions on a paper. In the last, they are
Thank you, Chairperson, for those kind words. This is the agenda on which I will follow my talk. The first point we are going to discuss is action profile of basal insulins. I think before we understand that, I think physiology has to be understood. That during the night we are not eating anything, and the sugar levels are still maintained either by shutting off the insulin secretion or by increasing, so that increases the level of insulin. And then in between meals, again you require the presence of insulin so that the sugar levels are maintained, and that is the basal insulin. And as you can see, the red circles which are drawn, if you combine and extend them, there has to be a single line. So the first principle of any good basal insulin is that it has to be peakless, its action has to be uniform. That is the first prerequisite of a basal insulin. Let's look at what is the effect on the three major organ systems of the basal insulin. First is the hepatic production of glucose. The nocturnal hyperglycemia takes place because of the excessive production of glucose by the liver. There is increased lipolysis, and what happens? The action on the muscle. So here in this particular slide, if you look at the left, which shows the hepatic glucose production, if you see that from the marginal increase in the insulin level in the portal vein, portal vessels, that there is a increase in the blood sugar, and if there is a little excess of insulin in the portal vein circulation, there is a marked hypoglycemia by reduction as much as